Assalamu alaikum. Mohammed Arafat, emergency medicine physician at King Khalid University Hospital here in Riyadh. I will start my talk with this small case. So we received a 35 years old lady, medically free, presented with 2 days of shortness of breath, palpitation, and chest pain. Her vitals is stable as mentioned. So we work her up. ECG was fine, sinus, chest X-ray was fine, all labs normal. We end up ruling out pulmonary embolism in her, and this is the CT result. Bilateral subsegmental PE. So my talk will be about outpatient management versus admission of pulmonary embolism patients. So who will discharge this lady? Just anyone will be able to discharge this lady, given the fact that she's healthy, vitally stable, with no any complications? No one. So we all agreed about admission. Okay. So the literature started to study these issues or outpatient management of pulmonary embolism in the late 90s. There is a lot of clinical prediction rules, criteria, and studies, meta-analysis about this topic. I'll just go through the most important ones. And this is one of the earliest clinical prediction rules that predict mortality in pulmonary embolism patients. This was in 2005. The score called Pulmonary Embolism Severity Index. They randomly allocated 15,000 patients, 10,000 for the derivation, and 5,000 for the internal validation. Then again, they externally validate this result in 200 patients. The primary outcome was 30-day mortality. And this is the score. Age in years. If, for example, your age is 50, so 50 plus any factor. This is an 11 variables. After reviewing all the data of 15,000 patients with PE, they discovered this is the most significantly or statistically significant variables. And they divided the patients according to this into 5 classes. Class 1, the very low risk patients, for the mortality, 30-day mortality rate of 0 to 1.6. Class 2, the low risk patients with mortality rate of 1.3 to 3.5. And then they conclude that they derived and validate a clinical prediction rule that's safe and effective in classifying a patient with pulmonary embolism, but still external validation is required. Then at 2010, simplification of this pulmonary embolism severity index was there. So they reviewed all these 11 variables that were in the original study. They take all the statistically insignificant variables. They end up with these 6 variables. The age was only above 80 or less. They take off the gender, the respiratory rate, temperature, and the level of consciousness. So the simplified one is either 0 or 1 or more. If your patient got 0, it means that he's low risk with mortality rate of 1%. If the patient got 1 or more, so this is a high risk patient with mortality rate of almost 11%. So in summary, they conclude that simplification of pulmonary embolism severity index does not affect the accuracy of the prognostic tool, although still external validation add more support to the rule by randomization controlled trial is needed. Then in 2011, HISTA study, also it was a multi-central prospective cohort study in 12 hospitals in Netherlands from 2008 to 2010. They evaluated the safety and efficacy of outpatient management of low-risk patients with PE by 5 days low molecular weight heparin followed by 90 days of vitamin K antagonist. So this is the variables of the study. If the patient got any of this, yes, so he or she will not be fit to be as outpatient management. And For this study, the sample for the outpatient management patient was around 300. The primary outcomes was recurrence of thrombosis, major bleeding, and mortality. So 6 of these patients have recurrence of thrombosis, 0 fatal BE, and 5 non-fatal BE, and 1 with DVT. For the major bleeding, only 2 got major bleeding. 1 was fatal intracranial bleed, and 1 was like only muscular abdominal wall bleeding. And for the mortality, 3 of these patients died. 1 only from this intracranial bleed that's by the medication or the anticoagulant, and 2 from other causes, mainly cancers. Then they conclude that HISTA score may be safe and effective in categorizing patient or risk stratifying patient with pulmonary embolism for outpatient management. Still, extra validation is required. And here we go. At 2011, the first randomized controlled trial for outpatient management of pulmonary embolism patients. This is an open-label non-inferiority RCT. It was done in 19 hospitals across US, Swiss, France, and other European countries. They randomly assigned patients with low risk according to Pulmonary Embolism Severity Index, Class 1 and Class 2, either for outpatient management or inpatient management. The outpatient arm, they receive again 5 days of low molecular weight heparin, followed by 90 days of vitamin K antagonist at least. The primary outcomes was recurrence of embolism or thrombosis, major bleeding, and mortality rate within 90 days. 344 patients were eligible into both arms, so they end up with around 170 patients treated in outpatient setting. Out of this 170 patients, only 1 patient had recurrent PE, and it was after 80 days of outpatient management only, and it was also insignificant subsegmental pulmonary embolism. 3 patients got bleeding, 2 intramuscular, 1 menorrhagia, and 1 mortality case. And the mortality case in the outpatient group was a patient who died from acute traumatic aortic dissection. In the inpatient group variously, there is 0 of the complication and 1 mortality, and the mortality was also secondary to cancer. Say they conclude from this RCT that outpatient management of pulmonary embolism is not inferior and safe as inpatient management for low-risk patients, according to the Pulmonary Embolism Severity Index. So this is other meta-analysis in 2012. They reviews a big number of studies. Also, they conclude that the result of the present meta-analysis demonstrate the safety of outpatient treatment and early discharge in selected low-risk patients. But the issue in this study or meta-analysis, the heterogeneity of the risk stratifications rules or ways to stratify the patients. So they recommend another meta-analysis or other study within a uniform manner of risk stratifications. This is the European Society of Cardiology 2014 guideline. Also, when considering early discharge and outpatient treatment of patients with acute PE, the crucial issue is to select those patients who are at low risk of pulmonary embolism. Also, Pulmonary Embolism Severity Index was the most validated score upon the available scores. This is the last meta-analysis also in 2016. They review all the existing prognostic tour for pulmonary embolism patients. They conclude that Pulmonary Embolism Severity Index and Simplified Pulmonary Severity Index has been the only widely validated and updated scores. Pulmonary Embolism Severity Index, the only one with a randomized controlled trial that support it. So they conclude, we provide an evidence-based information about the validity and utility of existing prognostic models in acute PE that may be helpful to identifying low-risk patients and safe early discharge outpatients. So at the end of this, is outpatient PE treatment feasible in general? From what we reviewed, from what going in the literature, it's in the horizon, it's coming. A lot of studies confirm or or shows the safety and efficacy of outpatient treatment of selected low-risk patients. But also the most important part is the restricted situation and standard of care for these patients. Can you apply this in our current healthcare status? The answer is no. Going through the evidence, the RCTs that was done, this is not an emergency department project. We should have a multidisciplinary teams, hematologists, nursing, educators. We should educate our patients in a highly manner about the complication of the disease, about the nature of the disease, about the medications, administration, and the side effect. We should have a direct access to the hospital for our patients. Most of the studies, they provide the patient with almost a daily follow-up in the first week, and the others, they have phone access all the time or hotline to a clinical care provider to discuss any new symptoms or any issues about the disease. So in our current status, will not be able to do this. Please don't do this until in the next future we got other support or further support with the evidence about this, and we have this facilities to do. Thank you so much.